Sure. So just quickly, this is, I love this case because for various reasons, but I think it kind of shows some of the power of CT. So this is a kid who came in with classic case of myocarditis, and we have an MR, which I'm not going to spend the time to go over, but just beautiful, probably one of the nicest cases of myocarditis I've ever seen. Beautiful T2 mapping, not that you need it, positive on T2s, global relative enhancement, T2, edema ratio, all this stuff. But I mean, it doesn't really matter. The kid has classic myocarditis. But the cool thing about this case was, so he, for some reason, even though this was the most classic case of myocarditis, again, you can see this subepicardial enhancement, it was all over the place, was that even though he had the most classic case of myocarditis, classic history of had a viral illness and then developed chest pain, had a big troponin bump, the peds cardiologist wanted to exclude a coronary anomaly, which again, to me is kind of insane, but they were pretty adamant about it. So I said, well, hey, turn a negative into a positive. Why don't we do some dual energy stuff with some delayed enhancement? So I think this just kind of shows the power of CT. So this is a 4-minute delay using dual energy, so 40 keV, so very low tube potential. And you could see quite dramatically the degree of enhancement on the CT. I mean, really striking. And we also did an early phase, not surprisingly, as coronaries were completely normal. We also did an early phase and showed that there was hyperemia, and then, which I think is this, yeah, so here, so there's hyperemia in the areas that show enhancement. And then again, I just showed the delay, and then using some, I don't know if really tricks or not, kind of nulled the myocardium, if you would say. And if this will work, scroll through it, kind of, maybe, if this will work. Oh, my Lord. Okay. And you can see here, kind of turn the myocardium darkish, and then you can see all of the contrast uptake within the myocardium on CT. So I thought this was a just dramatically striking case of myocarditis, but also, again, showing what I think is very underutilized use of CT if the patient has a contraindication for MR. So I thought that was pretty amazing. I had never seen a case of myocarditis or any case of delayed enhancement this pronounced. And again, this was a few hours after the CT or after the MR. So, not that GAD would be this bright. But anyways, I thought that was pretty cool. This was a case that we just had, not really a conundrum in terms of the diagnosis, but just an impressive case of a patient with a large mediastinal liposarcoma who came in with basically symptoms of right heart compression, and you can see here this very ugly tumor, very large, a lot of fat attenuation, but of course a lot of soft tissue attenuation, kind of multi-lobulated, and you can see what it's doing to the right heart. The right atrium's almost gone, the right ventricle is quite compressed, very large tumor. And unfortunately, when they went for resection, they tried to, when they were removing the tumor, they actually accidentally pulled off the free wall of the RV, and the patient didn't survive. So the patient had radiation before, and I think for the tumor, I think he had a known diagnosis, and he had a prior bypass. And when they were trying to pull off the tumor off of the RV wall, he just took the RV with it, and the patient was deemed non-salvageable, and he passed away. This was a case I was showing. I think I sent out an email to some of you, just showing in a pretty impressive, whatever we want to call it, smoke artifact, in a patient who underwent a dissection study, and really quite pronounced in the arch and the transverse aorta and proximal descending thoracic aorta. This was an outside film, so we sent here for I mean, this was called a dissection. It was read appropriately by our trauma guys as a artifact, but the surgeons were not convinced and wanted a repeat study, so they did a repeat study, which not surprisingly shows that in a little bit more of a delayed arterial phase, that was quite early, that artifact had indeed gone away. So it was one of the more, I guess, impressive cases of smoke in the aorta that I've come across. Not really sure why. Yeah.
That's awesome. That is awesome. And I think the other thing too, Seth, is it shows why that there's slower flow along the undersurface, which may be why all those thrombi always occur. You know, the aortic thrombus always occurs in that location. You know,
that's actually quite interesting. I mean, you're right, they do. I never really thought of that. But you can see, you know, just a slower flow right along there.
Yeah.
And you know,
in fact, I have a thrombus that looks almost exactly like that, you know, from when I was in residency. That you know, it's the same location.
But this big?
I'll find it. Yeah.
Wow, that's impressive. I mean, we've seen smaller thrombi, but that's.
So, hey guys, the same thing happens with the way rivers flow, and they always erode their outer bank, and they form these big loops that way. That's why rivers become tortuous with time, because they keep eroding the outer surface, and then eventually the inner surface they actually fill in. So it really is a flow phenomenon that applies in other systems besides aortae.
Why do you think it's happening here in this patient? Why do you think we have this flow phenomenon? Brandon?
I honestly, I mean, it's clearly an earlier arterial phase. You know, why? I don't know. I really don't know why that happened specifically in this patient. I don't know if anyone has any other, I mean, I guess there's differences in flow characteristics along the course of the aorta, and if you catch it at the right time, one part's opacified and the other is poorly opacified. That's all I know.
What kind of scanner was it done on? That would be the other thing.
The outside, I don't know. It was so that was the first study I showed was an outside study. And the second, so I don't know what Stephen says, you know, trauma outside.
Yeah, you can probably look at the DICOM header and see if it was like a super fast scanner, if that contributes to it. I don't know.
I mean, I can look up. I actually think it was done on a flash or a high pitch helical acquisition. I think because I was actually impressed, because I think the hospital that had it, I was surprised that they had the scanner. But there have been a couple of interesting outside cases. But I'll check. It's definitely on the DICOM data, and I know on the anonymized data, the non-anonymized data, I have that information because it tells which scanner it is. So I'll let you know. But it probably is one of the high pitch helicals, given you know how well these coronaries.
If you put a region of interest, if you can, just say on an area like somewhere there, what numbers do we get more or less? 140 and
140, and then and then here it's 230, 240, or sorry, 330. So it's less than half. So it's a pretty dramatic change. But I saw that one. I'm like, honestly, I would have just said, whatever. But I know people talking about the paper, and it is one of the more impressive ones that we've seen. I think this case is really neat. This came from our VA. One of our fellows read it, and there's this infiltrative mass. It's infiltrative, but it's non-invasive. It wraps around. It's not fat. It doesn't have fat signal. It wraps around the heart. Well, really kind of interventricular septum, goes around the posterior wall of the right atrium, goes around the aorta and the superior vena cava. Trying to debate what this was, and then noticed that the patient had this bilateral, very irregular pleural thickening, also had this pericardial thickening, and was wondering, trying to put two and two together. And I said, well, maybe let's look. Anyways, this thing, it actually avidly perfused. This is the post-contrast. So here, I'll show the perfusion. So avidly perfusing. There's unfortunately, some wrap. But the T1 posts are very impressive in terms of enhancement. What was most impressive was the delayed. So now I'm like, okay, this is some form of fibrous tissue. What could do this? Pleura, pericardium. So I'm like, let's look at see if we get any views of the kidneys. And then sure enough, we get some view of the perirenal soft tissues on this delayed. And I'm like, maybe it's Erdheim-Chester. And got a MR, or sorry, PET. And it looks like only part of it came up. I don't know where the rest of it is, but crap. Anyways, it's pretty impressively the uptake around the pleura, the epicardial fat, and kind of invading around into the epicardium, along the soft tissue, the pericardium. And the kidney uptake wasn't that impressive, but on CT, there was a lot of soft tissue around the kidneys. So we don't have path on this yet, but given all the things that we saw, I'm pretty confident that it's going to be Erdheim-Chester, but we're still waiting to get path to 100% confirm it. And then the last case is not that exciting, but it's just a very pretty case of one of the denser livers I've ever seen from amiodarone on a non-con. Again, thin slices kind of ruin it a little bit, but this is a amiodarone liver with, let's see if I can do a little MIP here. See how impressively bright this liver is on the non-con. This guy was a guy with Williams syndrome who was on a very, very high dose of amiodarone for his congenital heart disease with pulmonary artery augmentation and arrhythmias. So the least exciting case, but a nice classic example of it. Unfortunately, he didn't really have any classic stuff in the lungs, although we were debating whether some of the consolidation he had in his right middle lobe and lingula, or down here, was a little high density, but and in the kind of right middle lobe, but we'll just leave that for the imagination.
Hey,
so
Seth, check out his thyroid.
Yeah,
Yep.
So
Pretty dense too.
Yeah. Does it concentrate in the thyroid as well?
It takes up iodine. Yep.
Okay.
Hey, I'm glad you brought up the question though of the high attenuation consolidation, because I had one this morning. A lady just recently started on amiodarone, and she has very high attenuation lower lobes, and it was mostly atelectasis, but I never know when to invoke some sort of lung injury because she has dyspnea.
Yeah, they talk. I've seen the more the ones. I've seen the classic ones that are involve the lungs, like one or two cases, and they're pretty impressive. I don't know at what point you like here. I didn't mention it in the lungs. I just kind of blew it off and just called it atelectasis, and I buried it, saying maybe there's some amiodarone toxicity in the lungs. Given that, it kind of left it because the liver is so clearly involved, and the guy is pretty much crumping because of his complete absolute heart failure.
Yep, Seth, look at his skin too. Anteriorly there, his skin is dense. So the amiodarone deposits in a lot of tissues. These people have a slate gray color to their skin. They've got iodine compound in their skin. Yeah, you can recognize these people out in the waiting room.
Really?
And the thing is that when you see dense lung tissue or you see dense skin like this, it indicates presence of iodine, but it doesn't indicate pathology. So any atelectatic lung that is stained with amiodarone is going to be very dense, but it's still just atelectasis. So the presence, the high density just indicates presence, not pathology. From this.
Interesting. Yeah. And I just haven't seen a nice liver this one, but this dense. But I didn't realize it went into the skin. That's actually quite interesting. And you're right. I mean, looking at it on the MIPS, there is some skin attenuation issue, so kind of interesting. All right, guys, those are my cases.
All right, thank you. All right, who's up next?
I've got a few.
You first.
All right, Trap.
All right, you guys see my screen?
Yeah.
This radiograph came in last week, and it reminds me of the case that David showed of the symmetric apical aspergillomas that the patient had. That's not what this is. This is a 20-year-old woman. Obviously, this is not what this is, but 20-year-old woman who presented in January with panhypopituitarism and was found to have granulomatous hypophysitis. They did a biopsy and didn't grow anything, but it was necrotizing granulomatous inflammation, and that was around this time. I guess I have the old CT. And at this time, her chest looks fine. They thought it might be tuberculosis, or I don't know if they were thinking cocci or something. But anyway, they started treating her with RIPE. And then she came in, got this radiograph and then the CT. And of course, everybody had looked at this. And when they brought this down and I reviewed it, you can see that she has these two large mass-like areas of consolidation, a little bit of surrounding ground glass, no satellite nodules. It doesn't really look great for TB, at least to me, especially because they never cultured anything. But the one thing I thought was interesting when I was talking to them too is the airways are thickened, and there's involvement of the posterior membrane. So there's a little bit of airway involvement too. And of course, I raised the question of whether or not this was going to be a vasculitis. They had not checked an ANCA yet. I thought maybe this was going to be granulomatosis with polyangiitis. And now, just yesterday, the results came back. This is the antiproteinase 3, I guess, is what they do instead of C-ANCAs now. So this is supposed to be the new test of GPA, and it's very high. And so they're pretty confident that this is going to be granulomatosis with polyangiitis. And this is a little bit of discussion from the rheumatologist saying the pituitary involvement is rare. But I thought with the airway involvement and these cavitary areas of consolidation, it was a pretty convincing, or at least consistent look with that. So,
wow,
just
yeah, very much.
Yeah, it looks like two eyes looking at you. So
what if you had sinus disease too?
Yeah, I just loaded this one. She had sinus involvement too. So yeah, I think they haven't checked her kidneys yet. I don't know. I just put this together this morning because I just heard from the pulmonary team, but I just thought it was a pretty impressive case. Now this next one, let's see, right there. This is kind of along the smoke theme, and I don't know. I'm becoming more and more inclined to think we should never time pulmonary emboli studies off the PA, because if patients have any heart disease, you frequently end up with something like this. And of course, I tell my residents, if you ever have a PE study that's apparently timed this well, that it's not due to the scanner, it's due to the patient having heart failure. And there's a little bit of smoke in incomplete filling in the lower lobes, which isn't the impressive thing, because you see here that there's really very little way to evaluate the left heart at all. And this guy obviously has a dilated cardiomyopathy. He has HIV, he's well controlled, but came in with recent onset dyspnea. And fortunately, they got an abdomen and pelvis CT at the same time, or shortly thereafter. So they scanned the PE, and then they scanned the abdomen and pelvis, because this guy has the most LV thrombus I think I've ever seen here. And there may actually be an arterial, or maybe it's a venous phase through the chest. Yeah, they did a venous phase through the chest for I don't know what reason, but I'm glad they did, because he also has some thrombus in his left atrium here. But this is like the most extensive clot I've seen in quite a while, all hidden on this PE study just because of our timing of contrast. Maybe you can window it down and hallucinate, but no, probably even not. So I thought this was pretty impressive. Now, to the question of his cardiomyopathy, I'm embarrassed to show the MR images because our MR scanners are not quite as good as what Seth shows, but he has some subepicardial enhancement too. And there's some various areas where he has this. And I think that he probably has some sort of myocarditis. I don't know, Seth, do you ever see like just a primary HIV associated myocarditis?
I mean, there's HIV cardiomyopathy. I don't know.
Yeah.
the infiltrate, like I don't know if it's acute myocardial inflammation or chronic myocardial inflammation with virus or unrelated. I don't know enough about it to say, this was, it's not an ischemic pattern.
Yeah.
So I don't know enough about, tell you the truth about it. I should, given our population, but about HIV cardiomyopathy and what the enhancement pattern is.
Yeah, I don't either. It sounds like relatively recent onset of cardiac symptoms over the last couple of months. So they may, yeah. I mean, the possibility even of a fulminant giant cell myocarditis was raised, but they may get a biopsy. I don't know.
It's funny whenever I see this with the thrombus, it's even though there's some subepicardial involvement, there's a lot of subendocardial involvement. I always just wonder about some eosinophilic or Loeffler's with the thrombus, but that's
his eosinophil level. Yeah, we're normal. The other thing I didn't show you too is on his thin A's, because the Loeffler's patients often will have reasonable function, and he just has no function. I mean, you can see why he's accumulated thrombus there. It's just
you're right.
Motion. Apparently, the echo said there were no wall motion abnormalities, but
that's an interesting place for the left atrial thrombus too. It's
I know it's a little weird. I agree. So, but interesting case. Now, and I'm going to show one more here, and then I can hand off since we've got a lot of people on here. But that leads me to this one.
Along that, your mention of the timing. We've been timing our PE studies off the left atrium, gosh, for 5 or 6 years, and it's very unusual to get a non-diagnostic study.
I've been met with resistance when I mention that, but I will. It
works quite well because there's contrast, because you'll see there's contrast still coming in, and there's contrast on the left side of the heart and in the aorta, so you get a free look at the aorta too. So we use it as our double rule out routinely because it looks better than the aortic studies.
Yeah, exactly. I mean, and it's, I don't know, we need to adjust our protocols because we're just wasting all of this contrast. So. No, I'm glad you said that though, Jeff. I may use that as more evidence to push us away from what we do.
I've gone to for many years, a timing bolus, like a test bolus of 20 cc's because you learn the patients that have the heart failure and able to, because it's not based off the first peak that it hits a certain thing, it's based on the curve. So we've seen a significant improvement with using that, but it's a little extra contrast and a little extra time.
Yeah. This one I'll show. This patient had a recent aortic valve replacement, had some coronary work done at the same time, and you can see he's got an intra-aortic balloon pump. The tip of the pump is, maybe not as high as we like to see it, even though I know we've talked in the past that oftentimes when they're placing these, they use the left mainstem bronchus as a place of reference. But that was on the 10th. He was doing a little bit better, and by the 13th, though, you can see it's a little bit lower right here, and his cardiac function was improving, but all of a sudden he developed abdominal pain, so they did a CTA of his abdomen and pelvis that day, and you'll see that he still has the intra-aortic balloon pump in, and this is the first time I actually have documented evidence that the intra-aortic balloon pump is too low and probably the cause of his mesenteric ischemia, or at least contributing to it with his low outflow state. There's his celiac axis, his SMA, still balloon right there. And you'll see he's got pneumatosis throughout his small bowel. And they took him to surgery, opened him up, and his entire small bowel was dead. And he was at 94 years old, so they put him on comfort measures, and he passed shortly after the study. But I think that, it was just the first example I've seen where it's really that low, because it goes, or where it's actually had consequences, because I know we talk about the ideal position and how if you have it too low, that it can cause these issues. And unfortunately, I don't know on this study how far up it actually goes, because this was just an abdomen and pelvis CT. But just a reminder, and we've actually seen a couple of new balloon pumps that are actually more visible than this. Clearly, they did not consult a radiologist when they designed these things, as we all know. But this was one that had snuck down too far and was contributing to his mesenteric ischemia.
So I think, Travis, you could figure out how high it went by the length. The balloon is 25 centimeters usually in these things. So you could You can extrapolate from the abdominal position and figure out where it would have been.
Yeah, I wish we had a CT. Let's see. We can figure out where the tip is right here. I think this is what you're saying, and then just measure up and see. That's 22.
Mm-hmm.
So it goes another 3 centimeters off of this image, and really then it would need to be about, I think the celiac is here, so 9 centimeters too low. I don't know. Maybe he's just a smaller guy, because assuming that it's similar to this, the 9 centimeters is going to put you somewhere up there.
Right.
So maybe he just doesn't have 25 centimeters from his arch down to his mesenteric vessels.
Did his mediastinum puff up between the two radiographs that you showed, or was it it looks fatter now. I just wonder if there was, he didn't have pericardial effusion on that CT scan.
No, I think he's just not taking as big a breath and has some small effusions. Yeah, there's no pericardial effusion.
Okay.
So, all right, well, I'll stop there, Jeff. I've got a couple more if we have time, but I know there's others on here.
All right, who's next?
I can show a couple of quickies.
All righty.
So my first case here is a man who has an abdominal lymphoma. So I'll show you the CT scan of his abdomen here, which is impressive for all of this upper abdominal lymphadenopathy here, which turned out to be a mantle cell lymphoma. He also has a pretty big spleen, probably also reflecting lymphoma at this point. And so then he has these abnormalities on his chest radiograph, on his chest CT here, which don't show up very well on his radiographs. So he's got all these fine nodules here. A lot of them are clustered out at the periphery. And people are trying to put this together with his abdominal findings of lymphoma. But as it turns out, a lot of our patients around here prefer Hickham's dictum to Occam's razor, and they have as many diagnoses as they damn well please. And it turns out this man has an interesting occupational exposure. He was a coal miner. So I think we have coal workers pneumoconiosis here, nice attempts at pseudoplaque even out here with these peripheral distribution of these granulomatous lesions here from his coal dust. And some of the lymphadenopathy here in his mediastinum lit up on a PET CT from outside, which I'm not showing today. So I'm not sure whether these were part of his, coal workers pneumoconiosis / silicosis, or whether that was part of his lymphoma. I think the only lymphoma that they were confident of was in the abdomen. So more than one disease here, in this case, coal workers pneumoconiosis, along with his abdominal lymphoma. So this is my second in a week here of incidental silicosis. Let me show you this this case, to a lesser extent here in left upper lobe, and a little deposit down here as well. And he has this CT scan. I think this is he. So this is his CT scan, and it shows these interesting collections of what appear to be small nodules that are conglomerating together. So is this infection here, or is this some bizarre sarcoid here? It's not none other case of coal workers pneumoconiosis, but we have these funny collections of things like this, and these persisted. He was treated with antibiotics outside hospitals, and again here, and there was no infectious cause of this. And this was ultimately biopsied, and this was a malt lymphoma. So this guy also has lymphoma, different from the last case, and this really looks more like sarcoid or infection to me. Have you guys seen malt lymphoma look like this?
I was going to show one.
I'm sorry, were you going to propose that from the radiographic findings?
No, I have a case of malt lymphoma that sort of looks sarcoid-esque. I was going to show today, so stay tuned.
Okay, we got a series now. a series of less than 100 cases.
I would have called this sarcoid other than it's asymmetric.
Sarcoid. Looks like sarcoid to me.
Yeah.
Yep.
Yeah. Okay, well, live and learn. And the interesting thing is he did not have any evidence of lymphoma elsewhere, but eventually I think he had some gastric symptoms, and the gastroscopist said the gastroscopist had no gross findings on endoscopy, but they biopsied and they found a similar malt lymphoma in the gastric mucosa and in the duodenum. So it was actually gut and lung involvement here, but it was invisible to the endoscopist. It was not visible on CT, his abdominal portion at least.
I think we should also remember that it's not rare to diagnose concurrent sarcoidosis and lymphoma in the same patient at the same time. That does happen, so you always wonder if he might have both.
That's a good question. It could be another case of pick'em stick'em, more than one disease. In this case, associated diseases.
Yeah.
And let me show you this guy who had CLL, got a stem cell transplant, had graft versus host disease, and was treated for graft versus host disease with corticosteroids, and was on voriconazole prophylaxis to prevent Aspergillus infection. And he has this big nodular, dense consolidation with surrounding ground glass, looking a lot like a fungal infection down here. So people who are on voriconazole or on Aspergillus prophylaxis who get what looks like a fungal infection makes us think about mucor. So as some zygomycete, which are often resistant to the agents that will protect against Aspergillus. So that was my first consideration. It turns out that this is a fungus. This is my first cases of Pacilomyces variati. I'm sure you guys have seen a bunch of this. And he was then, his treatment was changed from voriconazole to mycofungin and ambazone, and he got better in a couple of weeks. So this pathogen is nicely written up here by my main medical reference here, Wikipedia. This is a common thing in food, outdoor, indoor air, wood, soil, and carpet dust. And this man operated a mower on outdoor, parks for the city of Seattle. So he was exposed to grass and earth and things like that. And this is increasingly being recognized as a pathogen. So it's thermophilic, it resists heat, and therefore, it's interesting that this organism is detected in things that have been pasteurized, like pasteurized juices and milk, because it can stand high heat and stuff like that. So if your stuff is tasting moldy or looks moldy, it may be this organism. It's similar evidently to penicillium, and it is increasingly being recognized as an opportunist in compromised hosts. So he was on corticosteroids, and that's a classic immune compromise for this organism, it turns out. So I've only seen the one case. So it was fungal, it looked fungal, but it wasn't the usual culprit. When somebody's on Aspergillus prophylaxis, it wasn't mucor. Okay.
Great.
All right. Thanks, David. Well, let me show my lymphoma case here. All right. So I have two malt lymphomas I was going to show. And hopefully in a second you should see you guys see a CT scan?
Yes.
Good. So this patient had a history of a treated Hodgkin a long time ago. You can see the radiation fibrosis in the mediastinum, but then developed.
Jeff, we can see your database screen rather than your 2D viewer screen.
That's amazing because I can't see my database screen. Now you should be able to see it.
Okay.
All right. So it had been treated for a Hodgkin lymphoma some moons ago, and you see the paramediastinal radiation fibrosis, but then developed these lung opacities, and you can see in the left upper lobe this mass, air bronchograms, another one there, and those would fit for your more typical malt lymphoma, preserve the airways discrete. But what I thought was kind of odd in this one is this cluster of nodules that to me is a dead ringer for a galaxy sign for sarcoid. So, and then had these smaller nodules, and then another nodule in the middle lobe there. So, some kind of lymphoproliferative disorder. Obviously, when one lymphoma, it's not uncommon to see another one. But Yeah, this was a malt lymphoma, and I thought this was just looked like all over like a galaxy sign. Not as classic as David's case. I must have been confusing it with a different one, but sort of that peribronchial and then the the distribution. Here's the radiograph.
You may have both, right? In each, you may have both.
Yeah.
So-called, people call it sarcoidosis lymphoma syndrome.
Yeah, yeah. And then there's the radiograph just showing that opacity. And then my companion case is another malt lymphoma, but this is in a, and hold on, I'll make sure it shows it here. So this is, let's see, there we go. This is another patient. This patient has Sjogren's syndrome. So you can imagine where I'm going with this. Has some nodules, has had some heart surgery, given some RFI, but then has some cysts that are basal predominant perivascular. So some LIP, and then had this big mass. Now, granted, this is 2011. So you might wonder about, you know, they do get lymphomas with Sjogren's syndrome, but you know, potentially, if with some immune suppression, could also develop infection. But here's the same lesion. You should see 2 CTs now. There it is in 2017, so it is a little bit bigger. But it's been sort of smoldering along and developing a few more sites, more nodules now. So this is a indolent maltoma. Also has been biopsied. Now I think they're being treated with rituximab or something like that. Sort of the evolution of that, developing almost little cavitary sites around some of these cysts or some of these solid nodules getting more solid. So variations of malt lymphoma. So they tend to be very well defined, have air bronchograms, and they're often quite indolent, and sometimes they don't even treat them.
So Howard, could I ask you about your impression of the cysts and the bases here? Would you invoke some light chain disease in the setting of Sjogren's and some amyloid, or are you satisfied with just LIP for the basal cysts in Jeff's case?
Yeah, typically now when I do see cysts in patients with Sjogren's syndrome, I think the basic pathogenesis is protein deposition in the lung as the cause of it, rather than the LIP, although that the last is classical teaching. But I think that you don't need to invoke actual LIP to account for cysts. Rather, the common denominator is the deposition of protein, either non-amyloid or amyloid protein, but both derived from light chains.
Okay. Yeah, it's interesting because, you know, a lot of these times these patients have no symptoms, and I've seen cases of LIP without cysts. So I think Howard, I mean, we've discussed it before. I think that point about protein deposition is interesting and definitely plays into the whole process. Another interesting case, kind of along the lines of cysts. Let's see here. So this patient has some kind of urothelial cancer, and this is from 2016. And at that time, nothing exciting going on in the lungs. There's some rounded atelectasis in the left lower lobe, and then got a CT for surveillance. Had developed some metastases in the abdomen, and had these new cystic lesions in the upper lobes, well-defined walls, just scattered here and there, but really confined to the upper lungs, not much at all in the lower zones. One guy down there in the right lower lobe. So, I mean, common things being common, you'd think about metastases, but you know, you'd wonder if this guy started smoking or something else is going on. Another CT was done almost 2 months later, and shows that these things have gotten bigger and sort of more irregular. But turns out was not a smoker, had not done anything differently, was not using an e-cigarette, no marijuana, nothing. So obviously metastasis was a question, but it's just very unusual in that they're really in the upper zones, even had a ground glass nodule. So something strange. So had a VATS biopsy of one of these guys up here, and this is all metastatic urothelial carcinoma. And I mean, we don't see a lot of mets to the chest, but I sure have not seen cystic metastases from this particular tumor. And I was still taken back just how upper lung predominant it is, with just this one guy in the lower lobe.
So Jeff, you know, bladder cancer is famous for shelling out and cavitating when they're treated with chemotherapy. And so the explanation I remember from when I encountered this phenomenon, you know, 30 or 40 years ago was that these urothelial tumors are actually a kind of squamous cancer, and squamous cancers are the ones that like to cavitate. And part of what happens is that the lining of this tumor is producing these squamous cells which keratinize, and the keratin liquefies and gets coughed out and sloughed. So actually, these urothelial tumors are famous for cavitation with therapy. And I don't know where the therapy stops the growth and stops, producing more and more material that and allows the old material to cavitate. I mean, to be liquefied and coughed out or something like that, resulting in the cavity. But I've seen this when I see cavitary metastases. I think I ask whether it's a bladder cancer or some other urothelial cancer.
Have you seen them but they never were solid from the beginning, unless we just missed our window? And
I think you probably missed the window.
Okay, that makes more sense, because I have not.
I think they probably started out solid and then cavitated.
Okay. Well, that's.
Yeah, I don't know, Jeff. I've got some Cheerio cases that are urothelial cancer, and I don't know if I missed the window too, or if they just started out like that.
Yeah, I mean, because the first we saw them was on this February CT, very thin walled. I mean, they really look like cysts.
I have seen them solid turn cystic.
That's very helpful. I've seen the colon cancers do it recently, especially some of these mucinous tumors when they get treated. And I wonder if it's a similar phenomenon. They stop producing mucin, so they cough it out, and it kind of disappears, and you're left with the rind. Well, that's helpful. Okay, good, because none of us had seen that phenomenon before. We don't see a ton of metastatic, because the bladder cancers I've seen are just little tiny nodules. They metastasize, and I think a lot of them, I don't think they scan them as frequently. And then just a last quick case here. This is something we've seen a lot of, but it was one of the more profuse examples. Let's see. Here's the frontal view. So I can't remember this patient. I think it was chronic cough, and you'll notice there's sort of a fine reticular abnormality in the lung bases, but it's really it's very dense. But what's cool is I have a dual energy subtraction. So this is the soft tissue suppression, and you can see this is all calcium here. So you probably know where I'm going with this. But this is just a beautiful case of what I'm calling pulmonary ossification in a patient who almost certainly aspirates quite frequently. And you can even see some of them are branching, so that dendriform appearance. And that seems to be when I see this the most. I mean, that esophagus is a little ratty looking. It's an older patient, thickened esophagus, but just really exquisite pulmonary ossification. I know we've seen cases, but I seem to see this most now in aspiration. I don't know if you guys have that same experience.
But Jeff, do you see it in non-aspiration zones as well? Like we're getting pretty anterior there in the lingula.
Not really. I mean, you look at it, look at that gradient. I mean, there's the middle lobe is spared. I mean, the tip up there, I mean, there's a little bit, but people roll around here and there. He's got these other nodules. I don't know what to make of those, but I mean, look at the upper lungs. I mean, it's pristine. Mm-hmm. Right. That's just my thought. I mean, we see it with sort of this indolent type of fibrosis or recurrent low-grade inflammation. I've seen in people who've had like an old drug toxicity that's fibrosed, but it's not progressing, and they'll develop it. But I don't see it in people with IPF who are declining rather quickly, or people with sort of more rapidly progressive processes. Okay.
One case I showed a few months ago, similar to this, that had pathology, the pulmonologist had raised the possibility of chronic aspiration because most of it was intraalveolar rather than interstitial ossification.
Huh.
So.
Yeah. I don't know. It's just I have to as I see these cases, as I see it. I mean, I see this dense material, and I used to think people were aspirating, milk of magnesia or one of those Pepto-Bismol. But I think in having seen this enough now over years, I'm starting to think this is just how the body's reacting to this low-grade recurrent insult, and it's just whether it's due to the acidic environment causing calcium salts to precipitate, or if it's inducing a metaplasia from the injury. Just to sort of, I don't know whether it's a protective mechanism or what, but just something to think about as we see this. I mean, I can't prove he aspirates, but it sure fits the distribution.
It's got a hiatal hernia that would promote aspiration.
Yeah, although those are as common as hypertension, it seems like. So you need like 100,000 patients to see, just to have enough power to study that. All right.
How old is Jeff? How old is this man?
Older. He was in his 70s, I believe. Okay. Well, let me let Howard show some cases.
All right. Mine are pretty straightforward, but kind of interesting. So let me show you this one first. I'm going to show you these out of order. This, I'll withhold history just for a moment. You can see there's a lot of bilateral nodular parenchymal disease. There's pleural fluid. But the big finding is in the left lower lobe. So if you look at the opacity there, adjacent to a small amount of pleural fluid, it has the appearance of here very disordered aeration, and it's not enhancing as just atelectatic lung would be expected to enhance with contrast medium. And certainly we've seen this kind of appearance before with pulmonary hemorrhage and or hemorrhagic infarction as a consequence of pulmonary embolism. Of course, that's when we see it most commonly, when we do see it. This is obviously a lot of abnormality in the left lower lobe. And then as we scroll up, I will show you that there are two reasons to have substantial ischemia. If we go to the left pulmonary vein here, inferior, we don't see it, but we see this instead. And then if we go from above down and look for pulmonary artery inflow, we see it there, we see some lingula, but beyond about here, we don't see anything. So this is tumor, presumed to be tumor. This patient has metastatic sarcoma from an extremity, and I think this is all tumor there with occlusion of both arteries and encasement occlusion of the left inferior pulmonary vein with resultant substantial ischemia. And I think undoubtedly hemorrhage and or hemorrhagic infarction involving that lung. It looks quite awful. So a pretty dramatic case of that. He obviously has extensive metastatic disease to his chest as well. So I think there's no reasonable alternative other than this as an explanation, I think. And it is new from before. So this is last year in June. He has metastatic disease, but it has progressed substantially. This is a non-contrast. You wonder if there was some tumor there before, of course, yeah. All right, this one again is pretty straightforward, but I think it's maybe the first case that I've seen, I remember, in which we have acute aortic neural injury in the context of blunt chest trauma, pretty typical. So the lesion that is very typical is this one. At the aortic isthmus, it has all the features we usually see. And then just by chance, we happen to have at the same time a small one, which is an intimal injury right there. So that's in a typical location. This one is proximal to it. So in terms of, there's a classification system that interventional people use, at least in relation to the use of endovascular stents. So this would be a type 1, where there's really just an intimal injury, maybe a little thrombus, whatever that is. And then type 2 is intramural hematoma, which I've not seen. Type 3 is this one, which is pretty classic. And then if I remember correctly, type 4 is active extravasation from the aorta. So just an example of simultaneous type 3 and type 1. He had another, I think, exam just to clarify that this is a real thing rather than a pseudo defect soon thereafter, but there it is again. And yes, he did have an endovascular stent graft placed to manage both lesions, really. But this one should heal. So this one should not be treated with a stent. If it's the only one, this one, of course, yes. This one should be described as a type 1, for which a stent is not required, just observation. That's it, Jeb.
All right, thanks. We have a few minutes. Yeah.
Can I show the? I have one case I wanted to show.
Sure.
Seth, you still on there?
I think we lost him.
This is,
he's there. He's there.
This is the thrombus I was talking about that mimics his smoke. It starts here, goes all the way down to about the level of the left atrium there. And that's why when you showed that sagittal view, it looks so much like this. So this was a young lady who left AMA, and if I remember correctly, presented about a year later with dead gut from embolization to her mesenteric vessels. So this was the largest mobile aortic thrombus I'd seen, but I think this flow pattern kind of describes maybe why it forms along the undersurface here. And this is also, you know, where you usually see atherosclerotic calcification first in the aortas near the isthmus here. So I don't know if that's related too, but I know one of my attendings in residency was always suspicious of that.
What sort of attenuation do you get? Is this darker than the smoke was?
Yeah, this is real thrombus, I think. I'll give you a region of interest here, but it's going to be somewhere in the 30, 50, yeah. So I still refer to the article that was in 2006, I think, from Boston, where they talked about pulmonary emboli and the attenuation of a QPE being 33 Hounsfield units, plus or minus 15. And so, yeah, because they surmised that everything should be less than 93 Hounsfield units, which would be 4 standard deviations. So, yeah, I mean, this is definitely thrombus here. And it persisted. They actually did a PET CT on this lady, if I remember correctly, just because they were worried about an aortic sarcoma. It was so large.
And why do these things form? What was it about this lady that caused her aorta to thrombose like this? I mean,
good question. I've collected probably 15 of these. I've just been too busy or too lazy to write them up. Not all of the patients have atherosclerotic disease like this lady, and not all of them have known thrombophilia. So I don't know if anyone knows.
No, I think a large subset is just idiopathic.
And no one knows what to do with them either, because some of them may be treated with surgery or with stent coverage or with anticoagulation, and some of them resolve and some of them don't. So maybe chronic thrombus that develops here too. I don't know if anyone else has any answers, or if somebody wants to put together a big case series. That's probably the last one I'll show for now. I don't know if anybody else has any.
I have a case. I have one case.
Okay, Brett, that'd be perfect.
It's a pretty interesting case. So this, let me show this one. Okay, can you see the CT?
Yep.
Okay, so this is a befuddling, bemusing case, because this patient came to us from an outside hospital, and you can see here that there's what at first glance just, looks like it's probably an extensive intramural hematoma here that goes up into the arch vessels, comes down. You can see a couple of interesting things here. You can see maybe a focal intimal disruption right here, this irregularity here. You can see coming down, though, a little bit interesting that this seems to extend into the left main coronary artery. In fact, this gentleman I'll show you on a follow-up CT has had a large LED distribution acute MI and had a troponin bump. Here you can kind of see that maybe you might, I don't know if I would call that or not, probably not on this study, but extensive, what could be said to be an intramural hematoma perhaps, come down, goes into the SMA, goes into the renal arteries, but then you start to realize that it goes farther than you expect. I mean, this is well into the inferior aorta, goes all the way down, extends to the iliacs where there's compression of the external iliac, and it looks like almost, occluded external iliacs there. So I don't know if you'll have seen, intramural hematomas this extensive before, but something weird about this going on. And I'll show you, that was at about 1 a.m. I'll show you the same day, this is really very odd. About 12 hours later, the patient was rescanned, and this is what we have now. So you can see that the, let's just call it intramural hematoma for now, it much decreased by, perhaps a centimeter there. You can see that the intimal kind of irregularity is right there. Again, the part of it, this process that went into the left main has decreased. And let me show you going into the abdomen, this crescentic abnormality has decreased, and the involvement of the renal arteries has decreased. And look down here, the involvement of the external iliacs has decreased, and now they're patent. So very, very odd. Let me show you couple other things here. There was another follow-up CT here that we did internally, and now you can see the perfusion abnormality of the LV coming in right here along the anterior wall and the septum here. Coming down, you can see that. Let me show you the without. So you have to take my word for it, but on the first study, the process here was not high attenuation, but it became high attenuation on this follow-up scan. So now it looks like in this image, could this be an acute intrarenal hematoma? The problem is that it was not high attenuation on the prior scan. And the other problem is that it seems to be resolving much more quickly than you would expect a true intramural hematoma to resolve. And you can see here the high attenuation that was not present on the first scan. So we didn't know, we're still not sure what's going on. Is this an intramural hematoma that's rapidly changing? Is this some sort of, it doesn't make sense for vasculitis either. Let me just show you one last interesting thing that you typically see with an intramural hematoma, and I'll show you here. We talked about these before, intramural blood pool here in the descending aorta. Let me show it to you. Let me find it right here. You can see this right there, that side branch pseudoaneurysm or intramural blood pool down there in the descending aorta. Normally you see it connecting with an intercostal there. Normally we'd see that in intramural hematoma. And so overall, what do y'all think about this process? Because I've never seen this. If this is in an IMH that's acute, I've never seen one change so quickly in just the course of a few hours. And there's an MI here too, where there was some left main involvement and now there's no visible involvement. Just very strange. This same thing was involving the renal arteries and resolved on this particular scan. Have you all seen that rapid change? What do you think about this?
I think this is an acute aortic dissection that hasn't become classic in terms of you're seeing blood flow in the false channel. But I think the rapid evolution is that you've got hematoma in the wall. The reason it wasn't dense at the beginning is the blood probably hadn't clotted, and because the aorta is beating all the time, and you've got a fluid component there, you can massage it around and stuff like that. You can spread out and become, less thick in the regions where it was most pronounced before. At the same time, then as the blood clots, it becomes denser, and then you get the delayed high density in this thing. So I think this is an aortic dissection. If you got some more scans, you might eventually see that there's contrast flowing in a false channel, and it really declares itself as a classic dissection later.
I just find that hard to believe, because to go from this appearance, we're saying that this is the intimal, flap right here, where this is the false lumen.
Yes.
And then we're going from that to, let me bring this up again. Going from that to this.
Yeah, I think you've massaged some of the blood away that was in the wall. Because this thing is beating all the time, it can massage the stuff away. So I think it just moved around. It's spread out. I'll bet you this person presented with acute chest pain the way a classic aortic dissection would, and I think this is just form fruste of dissection. So I'm willing to listen to other ideas.
And do you think the left main change was actually dissection and stenting in there, and the same process kind of
just extending, right?
Yeah,
because I have seen IMHs evolve, a few days later into a classic dissection. I've seen, initially you had just a cuff of material around 1 lumen, and then, a few days later or a week later, you had classic blood flow in 2 channels with a intimal flap between them.
Yeah. It's very interesting. I've never seen one change so rapidly like this.
When we diagnose these, we don't image them multiple times. So maybe this kind of thing happens more frequently, and we don't really understand acute aortic syndrome very well. It's maybe more of a dynamic process than we appreciate. I don't know. I don't have any great ideas.
Yeah. All right. Well, thank you for
very interesting.
That's interesting. Okay. Well, thanks everybody.
Thanks. Yep.
Talk to you next week.
Okay. Bye, everyone.
Bye.